the annual event rate. Heart disease is really only part of the stories. Many people die with stroke, end-stage renal disease, and actually cancer. Next slide, please. Next slide. And this is really just showing that how microalbuminuria and also macroalbuminuria are independently predicting all-cause events, all events, and also EGFR are also predictive of events. Next one. Next slide, please. Next slide. Okay. And this is actually even in agreement. Studies from the West have also shown that people with albuminuria have about 50% increased risk of cardiovascular events in both diabetes and non-diabetes, and that again by reducing albuminuria using intensive glucose control is going to have major benefits on some of these events. Next one. Next one. Yep. Next one. Importantly, in this particular registry, which is very extensive in terms of risk factors and also complications and outcome, we have developed multiple risk equations. And here, once again, you could see that albuminuria, EGFR are all predictive of outcomes in terms of heart disease, in terms of stroke. And here with stroke, A1C is also predictive of outcome in a linear manner. Next one. End-stage renal disease, again, albuminuria. Next one. And even with all-cause death, albuminuria and EGFR are predictive of outcome. Next one. When we actually look at this Asia-Pacific cohort studies, here we have actually a large number of people, more than 160,000 subjects, half of them are Asians. You could see the importance of diabetes in actually conferring stroke risk in the Asian populations, again, highlighting that importance. The next one. There is now emerging evidence regarding the importance of cancer as the leading causes of death, as people are less likely now to die from renal failure and also heart disease because of interventional therapy. And next one. And in this next one. And in this analysis, one could see actually a near linear relationship between A1C and also risk of cancer. So that, and you could see the threshold starts around about 6 and 6.5%, and that even with an increase of 0.5% A1C, we could see that there is a substantial increased risk of cancer risk. So that 1% increase in A1C is associated with 18% increased risk of cancer. Next one. Now, in a recent meta-analysis, actually, Johnston looked at the 3 randomized clinical trials, Advanced, Proactive, and Record, which has actually reported cancer event rate. And here you could see that in the intensively treated group with an A1C of 6.5% and the standard control group, which is 7.5%, you see actually fewer cancer events within a shorter disease follow-up duration compared to a higher number of events in a shorter duration of follow-up. Next one. Although this was not reaching significance, there was a trend towards beneficial effect of reducing cancer risk with this 1% difference in A1C. And in fact, we estimated that between these intensive and standard treatment groups, there was 0.3% to 0.8% difference in A1C, and that's with a reduction of A1C. This has been arrowed down. There was a 9% reduction in cancer risk. And in our registry, we found that was 1% increase in A1C. There was an 18% increased risk of cancer risk, the next one. And put it another way, in fact, for every 0.5% reduction in A1C, you can actually have either a 9% increase in risk, or with a reduction of 0.5% A1C, you can have a 9% reduction in cancer risk. A very strong argument for actually reducing A1C all the way to 6.5%. Next one. Last point is about the age of onset, disease duration, A1C. Next one. And here again, using this cohort, so this is a very large cohort where we can compare Asian versus non-Asians. We can also see the effect of age. And here you could see that people who are less than 60 years old, they have much higher risk of heart disease, cardiovascular disease, and also all-cause mortality compared to the elderly people. The next one. And here again, we could see that the duration of diabetes plays a very important role in predicting cardiovascular diseases. As once you've got CHD, then your risk of stroke is also increased. Next one. And of course, when it comes to chronic kidney disease, disease duration, A1C, and these two, the interactions between these two factors are very powerful driving forces for actually causing this major endpoint. Next one. And therefore, against this background, one could see that according to the IDF, in Asia, this is Southeast Asia and Western Pacific region, the highest, the most rapid, the highest increase rate in terms of diabetes prevalence is actually in the young to middle age group. The next one, and if we use China as an example with the blue bar representing the men, the orange bar representing the women, you could see that over time, this is actually in the 1990s, and then this is actually in the mid-90s, and then this is, of course, in the 2010, the publications. Here we could see that the major increase is actually, next one, in the sort of in the young, with 5 to 8-fold increased risk of actually 5 to 8-fold increase in terms of diabetes prevalence among these young people. And of course, next one, is mainly driven by childhood obesity. Next one. And although I argue that Asians should have a lower A1C, in fact, I think this really data applied to Caucasians here. The UK PDS already show the actually importance of reducing A1C in actually reducing albuminuria, and this effect actually increases, beneficial effect increases, accrues over time, so that by 12 years, the benefit is actually very marked. Next one. And of course, when you actually see a cohort, if you look at the results, then in fact, if you stratify these patients, those patients who have previous cardiovascular, no cardiovascular events, and to glycemic control is not too severe, in fact, they do benefit from intensive glycemic control. Next one. And so here, this is really the scenario where very often we are waiting too late actually to treat these people, and in fact, we should be treating these people early and then bring them all the way down to 6.5%, stay there, rather than actually wait until glycemic control deteriorates and then actually plummet A1C down and give all the side effects. Next one. Next one. And again, highlighting that most of the benefits is seen with stroke disease, people with stroke disease duration. Next one. So ladies and gentlemen, I submit to you that I think ADVANCE has proven the benefits of lowering A1C to 6.5% on macro and microvascular complications, mainly due to nephropathy. Next one is over 30% of patients in ADVANCE were from Asia. Next one, Asians have higher prevalence of nephropathy and more likely to have renal disease, a major health burden in this part of the world. And that these two very important renal markers, albuminuria and eGFR, predict all endpoints of including CVD. And there is emerging importance regarding A1C control and cancer risk. And because young Asians are actually the highest, the most rapid increase in prevalence is actually among the young people who face long disease duration. And so, next one. There are, of course, now we have also got novel drugs which can lower blood glucose without causing hypoglycemia. And with those premise, I conclude, next one, that Asian patients should be treated early, safely, and intensively to an A1C target of 6.5%. Thank you.
Despite suffering a little puncture on the way of the slides, Juliana has cruised to the finish line.